Hi, good afternoon, everyone. This is Katie from AHI. Welcome to the Telehealth Learning Collaborative. I apologize about the delayed start. Fort Drum was having a little bit of technical difficulties logging in to the GoToWebinar account. So just bear with us 1 second while we log in and I get see who's on the line and get our presenter ready to go. So just bear with me.
Katie, can you hear me?
Yes.
And you should be able to go. It has started recording.
Yes. Thank you.
Okay.
Okay, so welcome everyone. So of course, as we always get started with, we like to hear from our friends at the state level. And I do see that Megan Program from the Department of Health is on the line. So I'm going to send her audio pin and she can give us a quick update about what's going on with Medicaid fee-for-service and the governor's budget bill passing and the updates from her end. Megan, whenever you're ready. Just waiting for her to enter her audio pin. There you go, Megan, you're ready?
I'm ready. Good afternoon, everyone. Can you hear me?
Yes.
Okay, great. The update from the State Health Department relates to proposed changes to the public health law, telehealth parity law, which Katie mentioned guides the Medicaid fee-for-service reimbursement policy. So based on the recommendations of the telehealth work group that met as part of the department's regulatory modernization initiative, the governor and the state Senate's budget bill for 2018-2019 expand the definition of originating sites to mean a site at which a patient is located at the time healthcare services are delivered by means of telehealth. And this has been changed so that it can include the patient's place of residence located within the state of New York or other temporary location located within or outside the state of New York, subject to regulation by OMH, OASAS, and OPWDD. So this section of public health law is also proposed to expand to add 2 additional types of telehealth providers, credentialed alcoholism and substance abuse counselors, as well as early intervention program providers and service coordinators. And then lastly, the definition of remote patient monitoring is also proposed to be expanded to include technologies that may include additional interaction triggered by previous transmissions, such as interactive queries conducted through communication technologies or by telephone. So as I mentioned, these changes are included in both the governor's executive budget bill and the state Senate's budget bill, and they would take effect 90 days after becoming law. The State Assembly's budget bill includes a proposal to actually repeal the current public health parity statute and replace it with new parity language for Medicaid. And it reads, medical assistance shall not exclude from coverage a service that is otherwise covered under medical assistance because the service is delivered via telehealth. And such services shall meet the requirements of federal law, rules, and regulations for the provisions of medical assistance. This assembly language defines telehealth broadly with no restriction on where the patient is located, such that telehealth means the use of electronic information and communication technologies by a healthcare provider to deliver healthcare services to an individual while such individual is located at a site that is different from the site where the healthcare provider is located. So currently, the state legislatures and the governor's office are working through differences in all proposed budget bills to reach an agreement by April 1st. So, so that's the update here from the Department of Health regarding the statutory changes.
Megan, is that something that you could summarize in an email or document to me that I can share with the group? A couple folks were asking.
Absolutely.
Okay, yeah, if you could send that to me in the next day or so, that would be really helpful, and I'll send it out with the meeting notes so that everyone's on the same page.
Great.
So the difference, if anybody was on the last Learning Collaborative call back in January, it sounds like, Megan, I know that in January you mentioned the originating site expansion with the patient's place of residence being now eligible. It sounds like there's been a few additions since then with the addition of the KSAC providers, early intervention program providers, and the expansion of remote patient monitoring. So that is definitely great news to be hearing from your department.
Great, thank you.
Okay, if you don't have anything else, I will go ahead and mute you. Thank you so much, Megan.
You're welcome.
Next up, we will get an update from the Office of Mental Health. I don't believe Amy Smith was able to join us, but she did pass along a quick update regarding OMH. So they are awaiting the Article 7 changes, which Megan just spoke about, before they will make any regulation changes. They want to ensure that their changes align with what's coming from the Department of Health. In an effort, I'm sure, based on those regulatory modernization initiative meetings, that the varying state agencies have a little bit more alignment in their telehealth regulations. So not much to update from OMH right now. From OASAS, I am not seeing Carmelita on the line. If anybody from OASAS who is on the line wants to provide a few updates, you're welcome to. I do see that Sarah Osborne and Rachel Fitzpatrick are on the line. If you would like your line to be unmuted, just raise your hand. Otherwise, I have an email from Sarah that I do see Sarah. Okay. Sarah, I sent you your PIN. As soon as you enter it, you'll be able to speak once I unmute you. Excellent. Okay, Sarah, you're on.
Great, thank you. Yeah, no, I just wanted to, first of all, I'm really glad to hear from Megan to explain the Senate and the Assembly legislative proposals. I was a little confused when I saw that they were going to repeal the whole article. But so I appreciate that there was replacement language. I somehow missed that. We have a regulation that is now effective, and we've been working through a process. We've been trying to develop an internal process of helping our providers, get their designation. It's turned out to be a little more complicated than we thought, but we really don't want it to be a hindrance to anybody. We're also trying to develop some kind of, just some help. Let me put it that way. Just some guidance or some help on putting together policies that would be consistent with our regulation, or trying to come up with language that could be included in, say, a hospital policy or an existing OMH policy where we have, providers that have dual certifications. Again, we want to make this as easy as possible and to get people going as quickly as they want to. So we're really just in an internal process of trying to figure out how we're going to go about doing that right now. So that's where we are.
Okay, sounds wonderful. I do have a question from Barbara Walton. So Barbara, your line is unmuted. I don't know if your question was for Sarah or for Megan, but go ahead and ask. Okay, never mind. All right, Sarah, thank you for sharing that information, and we certainly look forward to any changes that come from OASAS. And of course, as everyone probably knows, the OASAS telepractice regulations are finalized and are available on their website as of the end of January.
Yep, thanks.
All right, so I will move on now to our presenter. Our presenter today was going to be Fred Brayson from the Project Lazarus. He is on an airplane right now on a delayed flight, so Skip Rodenbush is going to step in. He is just as well versed in Project Lazarus and the telehealth initiatives that they are putting forth, and I am confident that he will give a wonderful presentation just as Fred would. So Skip, you are up. You can share your screen at any point and go ahead and get started. We'll just wait for him to get ready. Skip, are you on the line? Okay, well, while he's trying to figure that out, I have the presentation myself and can pull it up and he can speak to it if necessary. Waiting. There we go. Just trying to get his audio worked up. Skip, if you enter your audio pin, you will be able to speak. I apologize for the delay, everybody, while he gets that squared away. You have to enter it into your phone, Skip. So as soon as you do that, you'll be live. Everyone just bear with us while he gets that under control. Skip, if you are unable to get audio, we will have to cancel the presentation if you can't get that in. So you need to chat me and let me know. Thank you. Bear with us, guys, just one more minute. I apologize while he's trying to enter that audio pin. while he's trying to figure that out, I can at least give an update on what's going on the North Country Telehealth Partnership side. This way we're not waiting. I know it feels like a Monday, so I apologize. I sit on the 80K Action Committee, and that committee is all about, expanding rural broadband and especially in the residential community. And there's an interesting map that has just been put out for the Phase 3 funding awards that came through from the state. I am going to send that map out to everybody who is on the line today. That map is really interesting because you can look almost down to a street level to see where broadband, anywhere from 25 up to 100 megs is going to be available to you in your community. Especially in some of those more rural areas in like Hamilton, Essex, Clinton, Franklin counties. That's going to be really, really helpful for you to see that information. Additionally, the Center for Connected Health Policy has recently come out with a document for telehealth reimbursement in 2018. Some of you on the line may have seen this document already. It's more along the lines of Medicare reimbursement and provides a nice outline of how the Chronic Care Act, which was recently passed last month, is going to change some of the current Medicare restrictions. I'll be sending that document out with the meeting notes as well for your reference. But the Chronic Care Act is going to expand some rural geographic requirements starting January 1st, 2019. The following sites are going to be eligible originating sites and exempt from that geographic requirement, such as renal dialysis facilities for end-stage renal disease-related visits only, home care for end-stage renal disease, mobile stroke units for the treatment of acute stroke, and any other sites deemed appropriate by the Secretary for the treatment of acute stroke. So it seems like they're really focusing on that stroke and renal dialysis and stage renal disease population. Additionally, there's some chronic care management and remote monitoring updates where they have unbundled some codes to allow providers to be reimbursed separately for time spent on collection and interpretation of health data that's generated remotely. And lastly, beginning January 1st of 2020, Medicare Advantage plans will start being able to provide coverage for additional telehealth benefits beyond those already covered under Part B. And then, lastly, accountable care organizations are going to have some expansion under Medicare as well. Continuing with updates from our end, as you know, the last 3 years we've done a telehealth conference in Lake Placid every year. We are going to continue with that tradition and do a 4th annual North Country Telehealth Conference. This year, we are looking at the same time frame, probably the end of October, early November, and we are looking at moving the conference to Glens Falls. So a little bit more of a central location, not so far north. Granted, we love Lake Placid and our northern partners. We wanted to move it to a more central location. So you'll be seeing more information on that coming out over the next month. I am looking for speakers, so if anybody is interested or knows of somebody who would be great to speak at this event, please let me know. We're looking at expanding this to over 200 people this year, so it's really exciting. And lastly, our next Telehealth Learning Collaborative is going to be May 21st. That is a Monday, of course, and our speaker will be Felicia Parker from North Country Family Health. She's going to be talking about some of their school-based telehealth initiatives as well as teledentistry, something new that a lot of folks may not know about. I do believe Skip is on the line. Skip, are you all set?
I am, if you can hear me.
Yes, I can
hear
you.
Me? Okay. All right.
Yeah.
You did a great job of filling in the dead air. I'm sorry about that. But, I was fumbling around. So thanks for bearing with me. Hopefully this will be worth it. You can see my screen right now, and if you're ready for me to start, I will start, or we can chat for a few minutes.
Yeah, you are good to go.
Okay. I'd like to start all the way back at November the 20th of last year. I was on a video conference call with Greater Hudson Valley Health Services, and Middletown discussing designing and implementing a telehealth network to help them address population health issues in Sullivan, Orange, and Ulster counties. And on that call, the Sullivan County representative said she was really interested in replicating Project Lazarus. And to me, that was brand new. I had no clue as to what Project Lazarus was. So as soon as that call was over, I reached out to try to find out more about Project Lazarus, and I connected with Fred Brasson, the founder. And as Katie said, he's en route right now to Ottawa to present Project Lazarus to the Canadian government. And what I would kind of like to start with is, what our conversation was like when we finally met and hooked up. I asked him, how in the world is he doing what he's doing? And he said that he was going around organizing communities, very similar to, if you ever saw The Music Man, Meredith Wilson, Professor Harold Hill goes into communities saying, you got trouble here in River City, and you need a boys band. Well, his message was, you've got people dying of a drug overdose, and the only way you're going to be able to correct this is by coming together with, your telehealth as a connection, really, and being able to bring long-term care, to people suffering from all sorts of maladies, but at the same time, focus in on, I don't know who's running my show here, but it's not me. Is someone else running my screen? Hello? Hello?
Shouldn't be, no.
Well, the mouse is going all over the place. What are you seeing right now?
I see your screen, and it says Data and Evaluation, Public Awareness, and Coalition Action.
Okay. Well, I swear somebody, unbeknownst to me, was moving my screen. So the logic was, you look at what's going on, first of all, in opioids, because that's what we're talking about here. And 200,000 people have died since 1999, and half of them in the last 2 years. Now, that's really staggering. But this is a hockey stick curve, and there is not a place you can go where they're not talking about this. And obviously, that's why we're on this call today. And I'd like to preface my following remarks with the fact that if there's some interest, we can reschedule, and you'll have a chance to really hear it from Fred himself. But going back to the Music Man for a moment, I said, so you drive from town to town, basically bringing people together. He said, yep, that's what I do. I go in and give a high school, cafeteria, and we bring in law enforcement, we bring in the medical community, we bring in people from faith-based organizations, education, get the whole community together. And that's what the Surgeon General says it's going to take. Washington can provide the money, but the community's got to do it. But I asked Fred, had he tried to do this virtually, tried to do webinars and things of that nature? And he said, no, he hadn't. And I said, well, I can help you. So we quickly coalesced around the idea of creating a next iteration of Project Lazarus that takes advantage of technology. We call it PO 2020. Fred, and what he has done is now basically being recognized by SAMHSA, by HHS, and by OASIS and others as the kind of the go-to for community organizing and fighting back on this terrible epidemic. So the results, going back to when he first started this, and you all probably received a background story that came from Stanford's Innovation Center about the beginnings. It goes back 10 years ago when his county was third in the nation in deaths per 100,000 opioid overdoses, and that was in Wilkes County, North Carolina. He just basically being a hospice chaplain and seeing a lot of this firsthand, not so much the drug overdoses, but the disappearance of opioids from medicine cabinets of the people that he was chaperoning. It was basically couldn't stand by and let it go anymore. So he started organizing people, and they came together, and in a period of 2 years, they dropped the number of deaths from around 48 to 26 in the county. And then it went from there to being replicated throughout the entire state of North Carolina. What Project Lazarus 2020 was all about was to build on his accomplishments, but provide a wider adoption and scalability. His process, as you can imagine, was very slow, resource intensive and time consuming and expensive, and requiring representatives of Project Lazarus to visit communities, gain stakeholder acceptance, facilitate grants, customize programs, implement, document, measure outcomes, and maintain continued success. So PL 2020, which is what we introduced, basically takes all of this activities that would go on in the physical world and ports it over to an online program where you can recruit stakeholders from all these various areas, and you can deal with education across the board and start to quickly disseminate this wonderful program. And one thing that was lacking in Project Lazarus that we hope, and bear in mind that we're going back to November the 20th of 17, so we're very much at the early stages of this. What we want to do is add a care component which lands squarely into the requirement for a telehealth platform, period. And it brings together all those spokes of the wheel and directs it towards not just the coalition building, but actually creates access to clinical care, addiction treatment, and a 12-step recovery program built on best practices. And it's available on a subscription model. So what it incorporates is a customized website for the community where you can start to volunteer, be part of the movement, and that obviously links into the ability to provide care. This indicates a use of the application out into a kiosk that could be associated with a pill drop, which is getting drugs out of the circulation that should be disposed of properly. Having naloxone as a first responder kit, and also in first aid kits in public places, schools, you name it. So that this naloxone, if you're not familiar with it, and the reason Project Lazarus is called what it's called, is it basically takes a person whose respiration is just shut down and revives them. And they then need to be ported into ED to receive proper treatment. And that's where we want to do the intervention and essentially get involved in the ability to put them on a treatment program. Skipped ahead a little bit here, but this shows how telehealth is being used from, say, an ED department to first responders. This little red box is a product that we run across that works off of everything, satellite, and could go in an ambulance, so that there's no need to wait until you get to the ED to start treating somebody. You can actually do it with the direction of a doctor and ambulance. We are building a road to recovery application that also ties into this, so that it essentially can be a scheduler for activities, directories, videos that would help you in a overcoming a problem. Hopefully, affirmations and things of that nature. Ultimately, be able to reach out and get to your coach, your sponsor. Takes a lot of the loneliness away from people that are struggling with this, and it could also serve as a video hotline, and totally dependent on telemedicine. And then the recovery doesn't happen without medication, period, end of story. And we're linking with some of the best practices out there that have been using telepsychiatry to treat these people that are in programs. And our vision is that there'll be a lot more programs available. And with all the money coming out of Washington pouring into this battle, most of it would not have to go into hardware and software, but could go into recovery centers and get more docs involved in treating with the buprenorphine and other medications that are out there. So to kind of wrap this up, this just speaks to some of the people that we spoke to at the AATOD conference in Manhattan last week, and where they're coming from as far as movement in this area. Obviously, there's a lot of interest, and the kind of, like I said, to wrap this, the appeal in 2020 includes a professional services package along with helping design and project manage, training people, and help with grant assistance. One of the questions that Katie had posed before we got into this final version was, where was the need for telehealth and telemedicine in the current existing Project Lazarus model? And this is all available to you, so you don't have to worry about taking notes here. But you can see it's pretty much everywhere. When you think of the transportation issues and the access to care, et cetera, all the things that telehealth really achieves. And I think the biggest takeaway from this all is, for all of us, is that the opioid epidemic is causing a great awakening to the power of telehealth. If you start with this epidemic and put in the infrastructure to address it, which many of you have or are looking to do, it can serve as a pathway for many other issues facing us. And with that, we'll get into some Q&A if you want to do that, Katie, or you want to take now and ask me a question.
Nobody submitted any questions, but I can think of a couple that the group might want to know. First and foremost, one of the slides had highlighted New York as a state that Project Lazarus is in. Can you cite any examples of where Project Lazarus is being utilized in our state, either from an in-person perspective or telehealth?
Right now, we are in discussions with 4 or 5 facilities. We can't really disclose that right now, but within the next 30 days, we will have some definite implementations happening. Okay.
And secondly, is Project Lazarus actually using telehealth at this time, or is it still in that development phase?
We're putting together the package right now. The thing to really hang on to is that all these pieces work, but combining them into a kind of a global view is what we're doing. There's no trial and error. It's just applying it, whether it's for long-term care facilities or if it's fighting the opioid epidemic. It's almost like, where's your pain point, and how can we design a solution around that? So I'm not dancing around that question. It's just that we're very, very deliberate about what we're doing, and we're leaning on some of the best practices that are out there. In the case of this 12-step recovery program, for instance, it's a live working mobile app that is in use right now, very early on, but it's out there. So we're coalescing and aggregating some pieces that will all run under, say, one dashboard. So
okay.
The short answer is it's in the works, but it's always going to be in the works. We're going to constantly be evolving, just as you would in any implementation.
In terms of New York State specifically, as you likely know, there are regulations through the Office of Alcoholism and Substance Abuse Services. Does your solution, fall under those guidelines and meet those guidelines? If practices were interested in looking at Project Lazarus as a solution, there's some requirements and regulation and technological guidance, and if you will, in New York State specifically. So do you tailor your solution on a state-by-state basis?
There's two answers to that. One is we have a very pliable software solution that can be customized to meet whatever the requirements are. And having said that, there is the ability to customize not just around the state level, but down to the community level. So the answer is we are going to comply with whatever the regs are, and we have a law firm that is guiding us on that in the state of New York and in other states as well.
Okay. And I apologize if I missed this, but does Project Lazarus, this telehealth solution in this package, does it include the option to bring in providers if a practice or organization or treatment center didn't have providers available on their own to devote to it?
That's absolutely correct.
Okay.
In fact, if you step back from this thing being the opioid epidemic, and you start looking at the money, Katie, there is, just in the last White House budget, they have $6 billion earmarked for 2 years. And the one that's being introduced probably today and going through Congress, I think, is calling for another 15 or 20 billion. And I challenge anybody out there to say what they would do with the money if they had it. And it's like we think that this is another bad move to just throw money at it. What we're about is helping deliver care and maximizing the benefits from this once in a generation opportunity. So we're very passionate about doing this and doing it right, and bringing in telepsychiatry or people dealing in hypertension or specialists in PTSD. Definitely, that's the crux of this thing, is that we can bring to a community that has the will to make a change everything that they need to go to war, basically, against this horrible thing.
Okay. I'm not seeing any other questions other than can the slides be shared with the group?
You bet. In fact, that's this last slide here. And what I would suggest, since this presentation that I walked you through is really laden with video. The wheel, for instance, that we looked at with the spokes, there's video clips in every one of those spokes. There's video of the Surgeon General, there's video of Fred that shows how all this is being done. And if you will click on the link that you see there that says, when you get to deck, it says interactive video version. And if you happen to want to put it on your iPad, you can do finger swiping and navigate. Very cool. And I'd like to hear back from all of you that do this as to what your thoughts are and how we can make what we're doing better. And it's all, in our mind, it's all about collaboration at the community level and at the technology level as well.
Okay. Thank you very much, Skip, for sharing that with us. Before we wrap up, I did not get to Bob Hunt if he had any updates on the Fort Drum side.
Yeah, just 2 quick updates. We're working on 2 specific projects right now. One's a regional video teleconferencing solution, pretty much centered around the 2 fiber networks, the Action Fiber Network and the North Country Telemedicine Project Fiber Network. I'll have more information about that on our next call, but essentially we're trying to lock down a standard that we'll utilize that is managed from a central location. And again, I'll have more on that on the next call. We're also rolling out a teleretinopathy solution. I can't go into more on that because we haven't publicly announced it yet, but by the time we have our next call, we will have done that, and I'll be able to give you a fairly intensive update on how we rolled that out and how we're doing that locally as well as in the cloud, and a pretty exciting opportunity. But that's all I've got for us right now.
Okay, thank you. That pretty much wraps it up. Again, looking for speakers for the telehealth conference, so reach out to me if you have any ideas, and I will be sending out meeting notes over the next several days. Our next call, again, is Monday, May 21st at 2 p.m., so I look forward to talking with all of you then. Don't hesitate to reach out in the meantime. My email is kcook@ahihealth.org. All right, have a great Monday, you guys. Thank you.
Okay, I've